Hello, everyone. Welcome to our March ICARE Case Conference. I'm Tua Pal, and I'll go through a few housekeeping slides first. Just to give folks an overview about ICARE, I know there are some guests that are attending that may not be as familiar with what we do. So we started this in 2010. It's really an effort to engage both providers as well as individuals with inherited cancer predisposition. We have grown our registry through this partnership to over 8,000 at this point across the US and beyond. And this has enabled us to perform translational studies across health services delivery as well as basic science. Now, we are very excited for our upcoming case conferences that we have scheduled, and there are more that are in the works to be scheduled as well. And these are all available on our website. Our case conferences, we've done over 150 case conferences to date. And since 2019, we've actually started posting the presentations on YouTube. We recognize that providers or attendees can't always attend at this time. So these are available on our YouTube channel. So if of interest, please feel free to subscribe. We're close to 900 subscribers at this point. And then as part of ICARE, we also are really committed to keeping up to putting out information about the latest advances, because we do realize that finding resources is a challenge because we experience that ourselves. So we have a website which is searchable. We also do targeted emails with clinical updates as well as research advances and opportunities to ICARE participants. We're active on social media. Our handle is @inheritedcancer. On your social media platform of choice. And then with newsletter, we have we put out a newsletter twice a year. And again, it's got clinical updates, research opportunities, etc. Again, available on our website. Like I said before, we have a searchable website, which is searchable for our newsletter content, social media posts, as well as presentations. Sorry, it went forward. So the existing resources we have, as I've already mentioned, website, social media, biannual newsletters, as well as some of the other resources. So when patients are referred to ICARE, they can be part of new discoveries, get care updates personalized to them, as well as finding out about other studies. We've tried to make it super easy to refer to ICARE. So we have online referral forms that we can send to you or that you can access directly, as well as prepaid postcards that we can send to you. The other thing I wanted to make a call for is for these case conferences, what we are really encouraging is for people to also submit cases. This is a great forum to be able to get feedback about your cases. And we do thank our colleagues that have presented in this forum in the past. Here are examples of our social media posts. In terms of ICARE focused efforts, we continue to conduct a study focused on the genomics of hereditary breast cancer, co-led by my colleague at Vanderbilt, Dr. Sonia Reed. So with that, I wanted to go ahead and present the first case and then introduce our guest speaker. So this is a family that I saw a few weeks ago. And what you see here is a 37-year-old with a PALB2 mutation. So the way this came to attention actually is that her daughter initially had ALL. She went into remission and subsequently had medulloblastoma and is currently in hospice. But again, the patient, the daughter had been seen earlier. They had attributed it to some chromosomal duplication. However, the mother pushed for additional testing because the daughter also had small size and some other features. So that's when she was found to have a PALB2 mutation that was homozygous. So it was the same mutation on both alleles. What's interesting is the couple are non-consanguineous, but she and her husband are amongst the 5% of Christian Jordanians. So again, I don't know how much testing has been done in Jordanians, but they had no knowledge of being related. But with having the same mutation, they probably are many generations ago. The son has been tested and is heterozygous. They're possibly interested in pre-implantation genetic testing, possibly through a surrogate. When we look at the family history for the proband, again, there is breast cancer. Quite a strong family history of breast cancer, actually, when we look at it, multi-generational. On her husband's side, I don't recall that there was a huge family history. So again, the family size wasn't super big, but I don't have it on this pedigree. So when we ran the CAN risk, the 5 and 10 year risks were pretty high. Next 5 years, 2.2%. Next 10 years, 6%. And then when you look at lifetime risk, it's about 50%. Ovarian cancer risk, not surprisingly, are fairly low. So, with that, I want to discuss this case, but first, I wanted to introduce our preeminent guest expert who will be talking to us about PALB2 updates, contralateral breast cancer risks, and outcomes. So, our guest expert today is Dr. Kelly Metcalfe, who is a professor and associate dean of research at the Lawrence S. Bloomberg Faculty of Nursing and Faculty of Medicine at the University of Toronto, senior scientist at Women's College Research Institute, and she conducts research on how to prevent and treat cancers in those genetically predisposed to develop cancer and many other topics related to inherited cancer. We're really grateful to Dr. Metcalfe, or Kelly as I call her. She is a longstanding friend of mine, for doing this presentation. She's been collecting these families for many years because we've been working together many years on this. What she's going to be presenting is data that is not yet published, but that will be submitted as we finalize the analysis for publication. So, really exciting. Kelly, can you give us some insight or any thoughts on this case?
Thanks to and thanks for the invitation to be here today to present some of the work that we've been doing together. And I think it's interesting to see these types of families. And I think what's noteworthy about this is the extensive family history for maternal aunts with breast cancer. And it doesn't sound like this family history was ever discussed in the past. It wasn't until the proband's daughter presented with her cancers. So I'm curious about that discussion that you had with the woman, and really there's a lot of at-risk cousins on the maternal side. Um, so thinking about cascade testing and the importance of cascade testing in this family. So I'm just curious about those kind of discussions that you may have had with this proband.
Yeah, so yes, we had those discussions. The way she actually got tested initially was once her daughter got tested, she got tested on the pediatric side. So
Mm.
her daughter was a patient in the pediatric hospital at Vanderbilt. We have the pediatric oncology and the adult oncology. Yes, we talk to each other, but they're different services. So once that happened, she got referred to us. So she already came to us with some knowledge. You're right, it hadn't been picked up
Mm.
before. Um, and so when we have this discussion, we provide a bunch of different resources to families. So, one of the resources we provide is information about Connect My Variant, which is led by one of my faculty colleagues,
Mm.
Dr. Brian Schertz, who runs this not-for-profit on the side. He's also a molecular geneticist and faculty at Vanderbilt, but as part of his not-for-profit, he runs this service where what they do is they provide free navigation services to kind of advise on, well, how do you talk to family members? What we've also found with our own research, and you've probably found the same thing, is, when we're thinking about what we do for families, a lot of times it is the family sharing letter, which is great. However, this one and done approach is probably not enough in
Yeah.
many families. So with Brian's services, they'll do that. The other thing that he's done, and he's presented this in ICARE, so we have this, the presentation available for anyone that's interested, is through his research, he's found that say two individuals have the exact same variant, there's probably a 90% or more chance that they're related, right? Even if it's 8 generations back. And through this approach, what they've been able to kind of figure out is it does end up identifying more family members. It kind of rallies the family
Mhm.
together, builds new connections, and in some families, it's been an effective way to increase testing as well. But I agree with you. I am surprised that she wasn't identified before her daughter presented with Fanconi anemia. And
Mhm.
quite honestly, PALB2 we know is associated with Fanconi
Mm.
anemia. However, it's not really common. So
No.
this is like it's not a common cause of Fanconi anemia. It's just
Mhm.
pretty rare. So this is probably one of the first cases I've seen of Fanconi
Mhm.
anemia due to PALB2. But yes, your point is well taken. And beyond like the aunts, there's a lot of cousins at risk too.
Yeah.
So
And the proband is now in a really good, it's obviously going to be beneficial to her that this is being identified because she can do something about her cancer risks being only 37.
yep.
Yeah.
Yeah, and so now she's getting the high risk screening, obviously, um, and we'll take it from there. Like she's got
Hmm.
the option for surgery,
Hmm.
should she choose it. But I guess this will relate to your talk about contralateral breast cancer risk. So,
Hmm. Hmm. And
in,
all of those aunts who've had a previous diagnosis of breast cancer doesn't, although some of them are many years out, but and they are all a little bit older. But again, I think the cousins are really and ovarian cancer risk, although not as high as breast for some of those aunts who've had a previous diagnosis of breast cancer. And today I'm going to talk a little bit about the impact of some of the cancer treatments on the risk of contralateral breast cancer. So thinking about treating that first breast cancer as well.
okay, so we can get started with your presentation then, Kelly. Take it away.
Okay. Thanks so much. And I do want to thank ICARE. I think without the contributions from ICARE, from those of you who are referring, from the patients who have agreed to be part, that's been a major source of recruitment for us for this study that I'm going to present today. And like Dr. Powell mentioned, this is just an interim analysis. We are continuing to recruit patients into this study. We do have a very, very large cohort, internationally recruited cohort for this study. So I'm going to present some initial results. We're still analyzing this data, but we do hope to have some of these results out in the next couple of months. So at the end, I really just want to talk about this cohort of women. We know less about POLB2. I feel like we've really concentrated our efforts up until this point on understanding how women with BRCA mutations present, what their cancers look like, the best treatments, not only for the prevention of a new cancer, either contralateral breast cancer or an ovarian cancer, but also the impact of those treatments on survival. And so we have a lot of good data in BRCA1 and BRCA2. So this is really one of the first large scale studies to look at the impact of treatments or the clinical presentation of that PALB2 associated breast cancer on outcomes. Today, I'm just going to be presenting on contralateral breast cancer risk in this patient population, but obviously the end goal is really to look at survival in this patient group. So I don't think this is news to anyone thinking about the lifetime risks of developing breast cancer associated with each of these genes that we're typically testing for on our panels. Similar in Canada, where I am, that we do offer panel testing, and all of these genes are typically on that panel. But what we can see is that PALB2 really has a very similar lifetime risk to that for women with BRCA2 mutations, slightly lower than BRCA1. And then we see a drop with the other genes where they're really that moderate penetrance genes. But starting to think about PALB2, um, not as necessarily moderate penetrance, but high penetrance gene. And we know some of the risks, they've been reported in the literature. So for a woman like the proband that Dr. Powell was talking about, thinking about her lifetime risk of approximately 50% for breast cancer, 5% for ovarian cancer, and there is some evidence for pancreatic cancer. There has been one small study that has looked at women with PALB2 associated breast cancer, and they did see a poor survival rate. This was a study led by our colleagues in Poland, looking at patients in Poland who had been identified with a PALB2 mutation and followed. And we did observe a very low 10-year survival rate compared to non-carriers. So some of this initial data on PALB2 really drove us to want to investigate PALB2 associated breast cancer. How are these cancers presenting? What are the risks after they've been treated? In thinking about how can we use genetic information to inform decision making related to the treatment of a breast cancer if a woman does present with breast cancer and a PALB2 mutation. There also has been some study out of Fergus Couch's group at the Mayo looking at contralateral breast cancer risk amongst carriers of mutations in various genes. So you can see there in the orange box, that is the PALB2 carriers. There were 97 women included in this study. And what they observed when looking at the entire cohort of 97 women with PALB2 mutations was that the contralateral breast cancer risk was similar to non-carriers. However, they did describe the difference in ER positive versus ER negative tumors, and that's something that we were also interested in looking at. So overall, like I said, this is preliminary data that I'll be presenting to you today. It hasn't been published, but describing the clinical characteristics of PALB2, how do these cancers present? Looking at the risk of contralateral breast cancer after a woman has been diagnosed with an initial breast cancer, especially important when counseling the women on what type of decisions to make regarding the treatment of that initial first breast cancer. And then looking at factors that are associated with the risk of contralateral breast cancer in the future. So, like I said, this is a large international study. We had two ways of recruiting women into this study. The first was, if you look on the right there, the retrospective. This is chart only data that's being collected at some of the centers that are contributing to this research study. It is de-identify. We don't have, at the study site at Women's College, we don't have follow-up, a regular follow-up with these women, as opposed to the prospective arm where a woman self-refers into the study. They're then consented, and we follow those women every 2 years. And we also get very detailed family history information as well as their medical records from sites throughout the world. We've collected a lot of data on these women, very detailed characteristics, demographic characteristics, age, ethnicity, parity. Um, I haven't listed everything there, but we do have very detailed information. We have the information on the exact PALB2 variant, a lot of clinical characteristics that we get from the chart, all of the histologic subtype, all of the information that we need for staging, grade, hormone status, if there was a multi-gene signature score available, as well as very detailed information on the treatments. So surgery, chemotherapy, including adjuvant, neoadjuvant, type of chemotherapy, radiation, and other adjuvant treatments, including some of the newer systemic treatments. We're also collecting detailed information on that. We collect information on any new cancers, so that could be contralateral breast cancer, but it could also be any other type of cancer that these women develop after that initial diagnosis of breast cancer. We collect information on oophorectomy and salpingectomy, including the date that that surgery was done, and ultimately collecting information on vital status, including the cause of death. So this is a very robust data set in terms of the details that we have available on each of the participants. In order to be eligible to participate in this study, women were diagnosed with breast cancer, in situ and invasive breast cancers. We're including stage 0 to 4, diagnosed in 2000 or later with the PALB2 pathogenic or likely pathogenic variant. If they've had any previous diagnosis of cancer before that breast cancer, other than non-melanoma skin cancer, they were excluded because ultimately we're looking at survival as the primary endpoint for this overall study. So this is, like I said, preliminary data on 888 patients with PALB2 mutations and breast cancer. And I think I'll just note as we'll be looking for the publication to come out very soon. This actually has been updated, and we have now close to 1,100 women with PALB2 and a breast cancer diagnosis that met that eligibility criteria. So, on average, these women were diagnosed with breast cancer at a mean age of 49 and a half years, and we have about 5.5 years of average follow-up from the time of diagnosis for these patients. 4% of these women presented with synchronous bilateral breast cancer, but with the majority, 96% presenting with unilateral breast cancer. In terms of some of the clinical characteristics, you can see the staging. We did have a small number of women with in situ breast cancer, 57, even smaller number of metastatic breast cancer, stage 4, just about 3% of our entire cohort, with the majority of women having stage 1 or 2 breast cancer at time of diagnosis. Overall, about 3/4 of these tumors were estrogen receptor positive. Similar for progesterone in terms of HER2 status, 85% of these tumors were HER2 negative. The majority of women had ductal histology. In terms of the treatments that these women received, so 41% of these women had a bilateral mastectomy, which would be higher than we might expect with sporadic breast cancers, maybe a little bit lower than BRCA1 and 2, what we would see in the literature. 70% of these women were treated with chemotherapy, and many of these women were treated with either tamoxifen or an AI or both, remembering that 3/4 of these patients presented with ER-positive tumors. 37% of the women had oophorectomy, and we're still going through the data to look at that timing of oophorectomy and if the women had it after being identified with a PALB2 mutation or if they'd had it prior to a diagnosis of breast cancer. And we will be teasing that out in the final analysis, looking at the impact of oophorectomy, not only yes or no, but also the timing of oophorectomy on our outcome of contralateral breast cancer. So overall, you can see the cumulative risks of contralateral breast cancer in this patient population. You can see for when we looked at all of the subjects together at 15 years, there was a 26.4% cumulative risk of contralateral breast cancer, lower in those women diagnosed at the age of 50 or younger, or lower than 50 years. Slightly higher in those 50 years of diagnosis years or older. So this is higher than what had been reported in the Mayo publication with a small, like I said, 97 women with PALB2 associated breast cancer. So we also looked at the association of various clinical and treatment characteristics on contralateral breast cancer risk. And you can see it's quite significant, the association with oophorectomy. Those women who had an oophorectomy significantly less likely to develop contralateral breast cancer in the follow-up period. And we didn't see a significant effect of any of the other than grade, which we will continue to look at, but any of the other treatment characteristics on the risk of contralateral breast cancer in this patient population. We then looked a little bit more closely by ER status, and we only observed that in women with ER positive tumors, where we saw a 90% reduction in contralateral breast cancer risk associated with oophorectomy. We did not observe this in women with ER negative tumors. Again, looking at some of these other characteristics that we looked at, not seeing, other than age in this patient population, there was some significant findings there in terms of the older age being associated with higher risk of contralateral breast cancer. In terms of other cancers that women reported after that first diagnosis of breast cancer, we did see 7 pancreatic cancers and only 2 ovarian cancers in 888 women with PALB2 and breast cancer. So that's something that we're interested in looking into further. It was probably lower than what we would have expected in this patient population, although remembering that 40% of these women did have an oophorectomy. So this very preliminary analysis, and like I said, we're working on this diligently right now to try and get some of these results out. Looking at the contralateral breast cancer risk, it was higher than what we would have expected and has been previously reported in the literature. But this is also the largest data set that has been reported on for this patients with PALB2 and breast cancer. So bilateral mastectomy actually may be something that a woman wants to consider for surgical treatment. We don't have the data yet on impact on overall survival. However, for some women, they make a decision that's not just based on survival, but also based on their risk of developing a new cancer, having to be treated for that cancer. So thinking about not just survival as that primary endpoint that women might be considering when they're thinking about the different surgical treatments that they may have. For women who present with ER positive tumors, which is the majority of women with PALB2 and breast cancer, oophorectomy significantly reduced the risk of a contralateral breast cancer in this patient population. So all of this information, especially as we're testing more and more women at the time of breast cancer diagnosis, they're being given their genetic test results then. It's important to use those genetic test results to make informed decisions that are right for that patient. And for some women, like I said, it's not just all based on survival, although we don't have that data yet. But it may just be that they have this high contralateral breast cancer risk and they want to reduce that risk as much as possible. I think this data also, as we have more and more data on the importance of knowing genetic status at the time of cancer diagnosis, again, I think this is more evidence that we need to test women at the time of breast cancer diagnosis if they haven't been tested before, because this information can be used to make more informed treatment decisions that will ultimately lead to better outcomes for these patients. So we're continuing to work on this. Like I said, we're up to almost 1,100 women from centers throughout the world, including ICARE, who has been a very important partner on this study. Tu and I conceptualized this study a really long time ago, so to see it get to this point has been very rewarding. Looking at bilateral mastectomy, not only for the prevention of that contralateral breast cancer, but also thinking about the impact on long-term survival, which we will be looking at, in addition to oophorectomy and the impact of that surgery on our outcomes, including contralateral breast cancer, ovarian cancer, and survival. So I'll just end. This is a picture of our group here in Toronto, and there are many collaborators. Like I said, we couldn't do this without them. More and more centers are signing on to this study, so we're continuing to do that. We're not only looking at PALB2, but we're also looking at ATM and CHEK2. So if you would like to participate and contribute patients to the study, please let us know. We'll be happy to onboard you for that, because we still have a lot of work to do in terms of these genes to catch up to what we know about BRCA1 and BRCA2. So I'll just end there.
Thanks, Kelly. That was great. I'm gonna wait for some questions, but I have some questions of my own, so I'll just start with those. Um, so I found it like it's fascinating, right? That the age of the contralateral
Mhm.
risk keeps going up above age 50. So we almost need to think of it in a different way compared to BRCA1 and BRCA2, right? So I'll just compare it to BRCA2 where say a woman gets a breast cancer after age 50 or after age 60 or whatever, right? In BRCA2, it's not automatic that she would have a bilateral mastectomy because the residual risks are not that high versus PALB2 looks to be different from that, right? So we almost need to revise our paradigm if this ends up ringing true.
Yeah, and that's a really good point. And maybe we need to be doing age-specific risks or something, when we do our analysis for helping women to understand what their risk is going forward after they've been diagnosed with that first breast cancer. But yeah, an important point. Like I said, this analysis was preliminary. We still need to look at it in more granularity. We still need to look at it by ER status because I think that that's going to be important. We still need to look at it by endocrine therapies. There's a lot of nuances when we're looking at this that we still need to be analyzing, and that's what we're doing right now.
Yeah, no. And then, the other thing I found fascinating is that how protective HRT is, right? In these individuals. Uh, no, not
Uh,
HRT, oophorectomy.
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 Yeah, yes.
Because if we think about absolute risks of ovarian cancer, it's 3 to 5%. So they're kind of on the bubble
Yeah,
for if we recommend oophorectomy. Do they have a oophorectomy? Sometimes it's like opportunistic because they're having another surgery, whatever, right? So it's not like BRCA1 and BRCA2, yet it really seems to impact their
yeah.
breast cancer risks based on this date. So again, I think that that's hugely important. The other piece of that would
Can
be,
I just, can I just, there is a lot of discussion now in these high risk carriers about the role of self-injectomy and, for the prevention of ovarian cancer in these high risk patient populations, especially for those who may not have as high of a risk. So not like our BRCA1 and 2 carriers, but someone who has maybe a 3 to 5% risk. Should we be thinking about self-injectomy as opposed to bilateral salpingo-oophorectomy? So, but this, it may be a different paradigm for those with and without a diagnosis of breast cancer. And I think that that's going to be important to consider because we've seen it in the BRCA research as well, the importance of oophorectomy in prevention of contralateral breast cancer, prevention of ovarian cancer, and also the impact on survival. So it's still an important conversation.
but Kelly, the reason it's different in my mind is with BRCA, the levels of ovarian cancer risk are so high,
I
it's
agree.
almost a no-brainer.
I
Whereas
agree.
this one makes you think twice because
Yeah,
usually in the BRCA context, yeah, it reduces their breast cancer risk, but people are mainly usually doing it for the ovarian cancer
I agree.
risk
Yeah.
reduction. So this
Yep.
almost flips that paradigm on its head, which I do
Yeah.
find interesting. But then the other part of my question is if oophorectomy, because salpingectomy, I agree with you, is a great
Mhm.
option, but is it enough? So I know we have studies now that are kind of looking at that. Again, I don't know how many PALB2 carriers there are, so can we
No.
extrapolate with BRCA1, BRCA2? Maybe, maybe not. So area of concern. But then the HRT question, as we discussed recently, also becomes something that I do think is important, right? Like Joanne Katsopoulos has done some amazing work with looking at estrogen versus estrogen plus progesterone, but looking at that in this population I think would be really meaningful from a, what do you call it, from a clinical standpoint, because like as clinicians, we get that a
Hmm.
lot, right?
Hmm.
And
Hmm.
even put like at the age of menopause, after menopause, if people want HRT, like what are the risks in these individuals? And then the last thing I was going to ask you is with this cohort, you can also look at characteristics of breast cancer in young versus old, and is that
Yeah.
at all different as well? But I'm going to stop because you have some questions from other people. So I'm just going to go through some of the questions from Becky Clark since we're comparing to the Mayo study, and I may have missed this. Did you
Mm.
see a difference in contralateral breast cancer risk in ER negative versus positive?
A very important question, Becky, and it's something that we are doing right now for the larger analysis of our almost 1,100. So we are going to be looking at them as two separate cohorts in addition to in addition to the entire cohort. But yes, we will be looking at it by ER status. So stay tuned.
Okay, and then another actually important question, Tiffany Lewis. Any thoughts on the number of individuals who developed endometrial cancer in your study? I was surprised to see that the number five was higher than
Mm.
ovarian cancer cases.
Hmm.
Good point.
Good point, but it probably has something to do with their treatments. Remember, many of these women were treated because they're ER positive cancers. Many were treated with tamoxifen or an AI, so that could account for the increased endometrial cancers in this patient population.
Okay, so some more questions from our good friend Dr. Jeff Weissel. Uh, Great talk, important project. Thoughts about cytotoxic treatment and late age contralateral breast cancer. There are interesting observations among Li-Fraumeni syndrome kids that suggest that treatment of cancer increases risk for new primaries.
Hmm.
Hmm.
Yeah, I mean, we didn't. It's hard for me to have a conversation when I can't hear from Jeff. But so cytotoxic, you're talking about chemotherapy, Jeff, I'm assuming?
Jeff, you can talk if you want.
Yeah, I'm talking about chemotherapy primarily.
Yeah. And we didn't
Radiation
see
too,
that.
obviously. We know about radiation,
Yeah.
but yeah,
Yeah.
chemotherapy.
Yeah, we didn't see it. Although we haven't, I mean, we have the details on the types of chemotherapy. I mean, even thinking about some of the new immunotherapies that are being used in cancer, in breast cancer patients. Um, Although our cohort is, when we think about when they were diagnosed, but I think we'll see more and more of that in terms of these new systemic therapies that are being used, and it's going to be important that we evaluate them in carriers.
Yeah, and I'll take the whatever prerogative to bring up the second question, which was,
Okay.
BSO reduces risk in average women, right? So it's not surprising that we see a risk reduction. Question is are the thoughts about risk reduction hormonal therapies like tamoxifen in this context?
Yeah.
We don't have great data, but there's such great potential there, and your BSO data really anchors the likely benefit of that kind of an intervention.
Mm-hmm. Yeah, well, stay tuned, Dr. Weitzel, because we will be presenting. I'm hoping the full data set at the meeting in Chicago. I'm sure Tua, you probably advertised that conference that will be happening in a month or so, and we hope to have this out for publication soon as well.
Sounds like something to have dinner over.
Okay, perfect. You're on.
Okay. So another comment question from Annie Argren. I may have missed it, but was there a delineation in women who had oophorectomies, how many were premenopausal versus how many women were
Yeah.
postmenopausal at the time of their oophorectomy?
Great question. And it's what we're diving down into right now too. Not only in terms of when in a woman's life this was done in terms of age, menopausal status, but also in relation to when the cancer was diagnosed. So some of these women may have had an oophorectomy before their breast cancer. I suspect the majority had it after, but we're looking at that, and I think that that's an important comment. In terms of PARP, we did collect it. I think our numbers are very, very low, though.
Yeah, and again, PARP inhibitors, advanced disease, there are trials being done. Again, people do use it off label as well. So,
Yeah.
and I think it really depends on the oncologist slash institution. Then I have another question here from Elise Bendick. At our institution, we're reviewing the tool that calculates risk for contralateral breast cancer. It looks to be at the Dana-Farber, a tool through them. We haven't done a deep dive into it yet. However, it seems to estimate risks higher than that provided in NCCN guidelines by gene, especially for older women. I'm curious your thoughts on this tool and how it compares to what you have found in PALB2. I'll just step in and say you can look at contralateral breast cancers through CanRisk, and they do regularly update it along with other risk factors. So when I am generating contralateral breast cancer risk, that is my tool of choice. It's built, as all of you know, on the Bodicea background. But Kelly, any other
Yeah,
thoughts?
and I don't know this tool at all from Dana-Farber, so I can't really comment.
Okay, let's go on to some other cases then. So again, I do end up seeing a lot of PALB2 patients
Mhm.
clinically, so a lot of these cases are going to be mine. But here's a 45-year-old that I saw. She had had triple negative breast cancer at age 37. She is status post bilateral mastectomy. She had chemo, no radiation, ovaries intact, reported genetic testing. Um, following diagnosis, but results weren't available. We had her retested through our Black women's study, and she was found to have pathogenic variant in PALB2 as well as RAD51D. Um, the thing is, she's a double mutation carrier, so I could not run CanRisk on her. So again, I thought it was an interesting case. Wanted to see what you thought. I know there are some family members here. Don't know which side of the family it's coming
Mhm.
from because of lack of family testing, but I thought it was an interesting case. But any additional thoughts?
Well, she's had a bilateral mastectomy if she's worried about her contralateral breast cancer risk. Is she considering oophorectomy?
Well, that's where I would say she probably should,
Yeah.
because I don't have a good way to estimate her risks, right?
Hmm.
Because we can't, like, none of our current risk programs enable us to do that for double mutation carriers, I don't
Hmm.
think. I mean, I guess with CanRisk, you could put in positive for both, but I don't think the algorithm
Would.
it takes that
Yeah.
into account because we just like it's almost a data-free zone, right?
Mhm.
But that being said, RAD51D in and of itself is an indication for oophorectomy, and then PALB2 is almost on top of that. So
Hmm.
that being
Hmm. Yeah,
said,
exactly.
at that age,
And the RAD51D is obviously a triple negative breast cancer risk more than anything else for the breast cancer risk that's associated with it, right? So you got a twofer there. What Kelly, what's the proportion of PALB2 for triple negative or for ER negative?
Uh, it's not very high, 25%.
Okay, I think earliest reports were closer to 40, I recall, like the
Um,
original papers, but so you're certainly adding to the spectrum of what we see. So it's just
yeah.
curious. So I would almost think in the myriad study where we looked at all the double primary care or double mutation carriers, we
Hmm.
didn't see any interactions like multiplicative interactions, but each gene carried its own risk, and generally the risk went with whatever was the highest risk gene that the individual carried. So, in this case, presumably the PALB2, but
Yeah.
hard to know if the triple negative status might be influenced by the
No, it's a good
PALB2.
point, Jeff, because we would have no idea, right? If
Right. Yep. No way to know. And but usually it's like which pathway did the tumor exploit? And you could look for tumor specific LOH.
yeah.
That should be informative for both genes. So
Hmm.
if you really wanted to know.
Hmm. But I
Yeah.
think her ovaries are probably the biggest concern right now.
Yes. And that's where I think oophorectomy is certainly on the table.
Yeah.
We're not seeing any ovarian cancer in the family, but with those two genes, both of which, especially at RAD51D, which predisposes
Mm.
to ovarian cancer,
And is the dad willing to be tested?
uh, last we checked, had not been.
There's a lot of relatives on both sides,
Yep.
especially when we're talking about two variants.
Yeah, and we expect them to segregate independently, right? So
Mm.
you might separate it out there and understand because mom's really young when she had her breast cancer.
Yeah.
So mom had lung cancer.
Oh, that's lung.
Yeah, LU. But again, it could have been metastatic. You know what I mean? Like these are
Yeah.
self-reported pedigrees. Mid 30s for lung cancer is also really, really
Very low.
young.
Yeah.
So who knows how accurate that is. There's another question here. Jeff, you might know the answer to this. Has CanRisk been updated for contralateral breast cancer? Last I heard, May 2025, CanRisk wasn't applying actual CBC risks. They were extrapolating from primary breast data. They do have much higher CBC numbers for PALB2 than NCCN says right now. I checked with Antonis and Mark, and I thought they were doing like estimates of contralateral breast cancer based on the data they had in hand. I can double check that, but you can tell, like they're definitely putting forth risks. I agree with you, though. Sometimes the risks look higher than I would have expected, um, especially for people that are younger. But yeah, I thought they were doing contralateral breast cancer risk based on the data they had. What Mark had told me was it wasn't like, again, take it with a grain of salt. It's not super duper accurate. Um, but they're doing it based on the data. Jeff, do you know more?
No, other than, it's similar to Ask to Me, where they're just using hazard ratios and things like that. The other thing you might consider when calculating it for this individual is project in the oophorectomy and then see if it comes out different. Then you'd know that it actually responds appropriately. But yeah, I'm not aware. I would just go to the source, ask Antonis.
Yeah. And I'm just thinking about it from a clinical perspective. And I mean, everybody on this call has probably seen a lot of patients. And I think you could tell them their risk of contralateral breast cancer is 35%, or you could tell them it's 80%. Often women have a decision in mind and it doesn't really matter the number. So if it overestimates it a little, is it going to change the mind of someone who says, absolutely, I'm not going to have a bilateral mastectomy? Or the opposite, if you go a little bit lower, is it going to change the mind of someone who says, absolutely, I want a bilateral mastectomy? So I think I struggle sometimes with those exact numbers. And I mean, we all know everybody interprets those a little bit differently and comes with so many other different experiences that may shape their decision as opposed to their risk alone.
Yeah, and you know what? You bring up an excellent point because in clinic, it's now been hammered into me, but like I definitely mention it. I just say, I'm giving you an exact risk, but we are not that smart, right? There's
Yeah.
going to be confidence interval around that. So it gives me a general idea of are you higher than typical PAL-B2 carriers or are you lower than typical
Hmm.
PAL-B2 carriers?
Hmm.
But again, these risk estimates are estimates. So they're
Yeah.
not 100% right, but they give us a little bit more. data because we can take into account breast density and
Mm,
hormonal risk factors and family history, which we couldn't do if we just looked at mutation status. But yeah, very, very important point.
yeah.
I'm going to go to the next case because it will go through some of the things you talked about, actually. So here, I'll tell you, it's 49-year-old female. She was originally seen at age 46 after she was identified to have a PALB2 mutation. Sister was originally identified after breast cancer diagnosis, and sister is status post risk reducing mastectomy. Patient had considered risk-reducing mastectomy and oophorectomy at the time, but planned to revisit in 5 years because she just wasn't ready. She's been having routine cancer risk management. A few months ago, found a very small lump in her left breast, pursued having ultrasound, which identified suspicious lesion. Subsequently, by a subsequent biopsy proven to be invasive. So she's got hormone receptor positive, HER2 negative, 7 millimeter tumor, grade 2. Also has area of DCIS, 10 millimeters. Treated with lumpectomy and came to see me to kind of discuss risks. And really, it was like timing going forward with the preventive surgery. So I ran her CAN risk. So this is a real case example that tells us estimated contralateral breast cancer risk was 58%, which threw me off, honestly, quite a bit because that is a really, really high risk. Um,
Mhm.
5-year, 10-year risks, again, are very high. Ovarian cancer risks are pretty low. But again, Kelly or Jeff, like, thoughts on this? Because this was a case that I was going to run by, or I may have even run by Mark, because the risks seem higher than what I would have expected for contralateral.
It's higher than you would have told her before she ever got breast cancer.
Thank you.
This is one I wouldn't show to the patient.
No,
No, I
she's
would
not
not.
even
I don't
50
believe
though.
it. I don't believe it.
You don't believe it?
No, I don't. That's higher than I'd quote a BRCA1 carrier.
Okay, that's what our numbers show. They're like at 15 years, if she's over 50, she's right on the cusp of 50, right? It was 35%.
Well, but this is
So
58%.
I know, but that's 30 years.
Eh,
I don't know. I don't know. It is a bit higher than you would probably think.
I
Uh,
always default to the simplest thing is that for BRCA it's 3 to 4% per year, while premenopausal drops to 1.5% postmenopausal. For
Yeah.
most of the other genes, it's
Yeah.
less than that. So even if I gave it 1% per year, we're still talking, it's not
Yeah.
going to get to 50, right? It's more
30%.
like
Yeah.
30%, which puts us
Yeah.
right in the number that you had before. So from
Yeah.
your studies, which is what I'd accept.
Hmm.
When there's outliers, you got to be a little concerned. And also, they're not working off of a mountain of actual data. When they
Yeah.
get your data from your study, then they can calibrate this better.
Yeah. And you know what? Too, she was ER positive too, right? So she would be treated with some kind of endocrine therapy. So I would
Yeah,
expect that to lower her risk.
absolutely.
Which CANRIS doesn't take into account, right?
Yeah.
Like they wouldn't have that. So again, this one surprised me. And again, when we come up with risks like this, as Jeff said, proceed with
Yeah.
caution.
Yeah.
Again, what we tell our patients for them to make their best decisions, we don't want to push them in one direction where we aren't confident
Mhm.
with this data.
Mhm. Mhm.
Um, and so here, basically what I said, much higher than I typically expect. She did have dense breasts, so BI-RADS C. She had OCP use, which was maximum, like the whatever the maximum is in um, CAN risk. And then there was that family history. So those were the only things that I could see in her risk profile that would have driven up her risk, but I would not have expected it to be driven up that high.
Mhm.
And then I have a comment in here. I stopped using CAN risk for contralateral risk after understanding this. And then there's a paper that's in the chat. I remember that contralateral risk was based on taking half the primary risk. Huh. That is concerning. I'm going to check with Mark to find out what's going on with that because it seems high. Let me just do one more case real quick. Here I have a 66-year-old female, PALB2 positive brother. So we have this emerge study at Vanderbilt, which is basically based on medical records. It's like we'll offer genetic testing without um, necessarily them being at super high risk. So we find people incidentally through this study is bottom line. So there's no history of breast cancer in the family. Side of the family that this mutation originated from is not known. Patient was hesitant to have an annual MRI because of the issue with contrast. And again, this comes up again, we have this in NCCN guidelines where the data currently, we don't have much data, but the data is not super concerning that that impacts the risk profile. So what was discussed with her is every 2 years. Considering her age, so she's unaffected, right? Her brother here doesn't have a cancer diagnosis, um, was the one who was the original proband. There's a sister here with neuroendocrine. Remember, there's a parathyroid cancer in her mom, dad's an only child. So you can see here, there's not much here in terms of family history, but let me go into can risk. Um, and keep in mind, she is 69, right?
Yeah.
So what we get in terms of 5 and 10-year risk, 5-year risk is 11.3%. Like that's super high. And lifetime risk ends up being, just shy, or it's 27.1%. Um, so again, I don't quite know what was going on with this risk assessment, but again, I know that the age distribution for PALB2 is shifted to the right? For
Mhm.
like compared to BRCA1, BRCA2. I wouldn't have expected it to be this high.
No, me neither.
Okay, so
Mhm.
and this is again, I think this reinforces the point that yes, these tools are meant to refine risk estimates, but I don't think it replaces our clinical judgment. So
Mhm.
when we get something that doesn't look like we were thinking, that is kind of something we should be.
She was 69, Tua?
Yeah.
So it's interesting because we are having this conversation now with patients in Canada because our high risk MRI breast screening stops at the age of 70. So
Hmm.
then they just go into regular mammography, clinical breast exams, etc. But so there are patients out there that are worried about their risk after the age of 70. And this really highlights, if this really was true, that they still do have an elevated risk of developing breast cancer in those remaining years between 70 and 80.
Yeah, the Carriers Project published that, right, as
Hmm.
well. PAL-B2 didn't look impressive, but certainly B1, B2 were warranting continued surveillance, right? So,
Hmm.
but still, this one's the same one, defies that same annualized risk calculation that we were just talking about. Puts
Doesn't
it at
make
almost
sense.
3% per year.
Yeah.
I don't buy it.
Yeah.
Sorry, that's a BRCA1 carrier who's premenopausal,
Hmm.
and
I know this one didn't
Yeah.
make sense to me either. The only other thing I would say is like she's older, so mammograms, like her breasts probably aren't very
Yeah.
dense. So
Yeah.
mammograms potentially could be enough. It's the younger women that we worry about with dense breasts that I would expect is really, really important. But as you get older, one would think that mammograms are get better. And again, that would be worth studying as well.
yeah,
Hmm.
well, she's got less time to accumulate gadolinium too.
Yeah. That's true.
That is true. That was a huge concern for her, by the way.
Interesting.
Anne or Lindsay, can you take me to the end of the slide deck? Because I think we are out of time.
Yes.
Yeah, the only thing that would make me worry about gadolinium more would be if the new FDA said it was okay.
Ah! Yeah, the
Uh,
whole world is worrying about that.
Well, but it's been there for years and years and years. I
Ah,
mean, I think we're gonna have to wait a decade or two and have some, important neurocognitive or other assays just to see what's going on. But I don't know. Everybody's not says okay.
Yeah,
mhm.
no, I agree. I didn't put in the slide this time. I think I just forgot. Like Kelly said, there is a conference in Chicago that's being hosted, focused on clinical cancer genetics that Fumio Olopati is leading. I think I don't remember the dates, April 25th. It's right after AACR. So we can send out that information in the email that goes out after case conference. Our upcoming case conferences in April, I have my colleague, Dr. Alex Bick, presenting on clonal hematopoiesis versus hereditary cancer, diagnostic challenges and clinical impact. Again, Alex is one of the leaders in this area, and I think many of us are getting these cases where we're
Mhm.
not sure if it's CHIP and what is the workup. So I'm really excited for that. And then in May, we have Dr. Alvaro Montero talking about refining classifications um, on a continuum. So BRCA1. We had Dr. Fergus Couch talk about BRCA2 last year. So this is a counterpart, BRCA1, that Dr. Montero will be talking about. So with that, I thank you for attending. Thank you so much, Kelly, for the great presentation, and looking forward to seeing how the data pans out and the publication. So thanks, everyone. See you next time. Bye.
Right. Bye, everybody. Thanks.